Diagnosis coding guidelines. While there is no one-size-fits-all rule for selecting diagnosis codes, here are some general guidelines to help you make accurate choices. Pain is a symptom, not a primary diagnosis. Pain is typically a symptom, not the main cause. For example, elbow pain could be a secondary diagnosis, but the primary diagnosis should focus on the underlying condition such as arthritis, a sprain, or tennis elbow. A common vague diagnosis is low back pain. Instead of coding for low back pain, without further details, ask what is causing the back pain. Once identified, code the primary condition and use low back pain as a secondary diagnosis. Preoperative and postoperative diagnosis. Preoperative diagnosis, conditions like lumbar radiculopathy or fibromyalgia. Postoperative diagnosis, these will usually remain the same as the preoperative diagnosis. Procedures performed, for example, lumbar epidural steroid injection or trigger point injection in the thoracic region. Avoid redundancy in descriptions. When providing diagnosis, avoid repeating the procedure in the narrative section. For instance, do not list lysis of adhesions as the diagnosis when it should be epidural adhesions. Include more details, such as whether the condition includes myelopathy, neuritis, or radiculopathy. Link diagnoses and procedures on the claim form. Each procedure listed should have a corresponding diagnosis. The procedures should be listed in order of their value, and the diagnoses should follow the same order. One exception is for fluoroscopic techniques, which do not require a unique diagnosis. Link diagnoses to procedures in documentation. It is crucial to document how the diagnosis is linked to the procedure. In the operative note, ensure that the first diagnosis matches the first procedure, the second diagnosis corresponds to the second procedure, and so on. This helps the insurance carrier understand the relationship between the procedure and the diagnosis. Avoid ambiguous terms. Never use terms like rule out, possible, probable, suspected, or working diagnosis, as they may lead to claim denials. Instead, document the specific signs, symptoms, or reasons for the procedure. For example, if a patient has back pain and the physician performs a facet joint injection to check if the pain is caused by facet joint syndrome, code it as back pain if the injection provides no relief. If it does bring relief, consider coding lumbar stenosis. Keep in mind that facet joint syndrome does not have a specific ICD-10 code. Use specific diagnoses. Always use the most specific code available. If referring to a syndrome like facet joint syndrome, identify the related conditions such as lumbar stenosis or other types of spondylosis with myelopathy. For example, use the appropriate code for lumbar disc degeneration, M51.36 or M51.37. Avoid not otherwise specified NOS codes. Avoid using unspecified codes, as they are often denied by payers. While these codes may be valid from a medical standpoint, they are often seen as catch-all codes by insurance companies. Make sure to explore all specific coding options before resorting to NOS codes.